Okay, everybody, this is Andrew Bennett. I'm going to talk with you now about the fourth and final pillar of what it takes to be a clinical faculty member. And that's obviously the nuts and bolts, the technical stuff that makes it work. I'm going to give you some examples of some things that have been helpful for me in my setting. Some of them you may be able to apply directly, others will not apply at all. Some you may be able to steal some ideas from in your own setting. I simply don't want people trying to recreate exactly what we do here. Obviously, that's not the intent. The intent is to leverage one another's experiences and skill sets so that we can grow together. So here are some basic suggestions from my standpoint. About 2 weeks before the clinical faculty take on the interns, the recommendation would be to wean down your Medicare load so that it is at about 25% if you have 3 interns, or less than 20% if you're in a 2-to-1 ratio. The reason I would recommend doing this is simply due to the compliance and regulatory components of CMS. These are not easy rules to follow in a multiple intern setting if you have many Medicare patients. Obviously, you can fill in the gaps with non-Medicare patients, and the interns can see Medicare, but you have to be certainly present for everything in a one-on-one model as outlined by the CMS guidelines. Second comment is all the patients that are primarily on the clinical faculty's schedule really should be transferred to the intern's schedule by the end of the second week. The goal would be obviously that your clinical faculty has only minimal, if any, patients that are physically booked on your schedule. Because you're essentially responsible for all the patients on the intern schedule. And so if your interns are seeing patients and you have patients on your schedule, then that really violates the model that we're looking for, or we've been using. Obviously, there's going to be some gut reactions. For example, if you've got a patient who's driving in from out of state, coming to see you, who really has a high affinity for you, you may choose to keep that one on your schedule. Or if you've got a patient that you've been seeing that's only a visit or two away from completing this episode of care, it may be more of a hassle to transfer them rather than you just see them an additional 2-3 visits and then complete the episode of care. So, but my recommendation is certainly by the second week that all patients, including incoming patients, new patients, would be set up on the intern schedule, and then the clinical faculty member would be overseeing all of those encounters. Setting up the intern schedule, I would recommend that you put 1 patient per hour initially. I guess over time this will progress to about a 30-minute time slot on the schedule, with the goal of having the patient in the facility, between an hour and 15 minutes, something like that. New patients, 60 minutes. Even when the intern gets proficient, you're still going to need a full 60 minutes blocked out without other patients on their schedule, because of the time that it takes for you as the clinical faculty member to go into the room and either A, help them through the hypothesis model or the physical exam component, or B, when they're proficient, you still need to be there for validation of the intern, receiving grand rounds, etc. So I would not recommend making that change at all, or diminishing that time at all. Productivity goals, I've outlined them below for you. 6 a day within the first 2 weeks, 8 a day within 2 months, and 8 to 10 a day by 3 months throughout the end of the internship. Again, these are just guidelines. These are things that I've done here in Texas. I do have a couple of interns, especially those that are more in the 2-on-1 model, that push 12 a day. But in the 3-on-1 model, that's 30 patients a day is a lot of bodies for the clinical faculty to keep track of. And I would not suggest you go beyond that. partially from the clinical faculty standpoint. The other is the interns are still in a learning model, and they don't know what they don't know. And so at about 8 or 10 a day, there's still time and ample opportunity for you as the clinical faculty to interject pearls along the way, especially those that are in quadrant 3 and quadrant 4 in their learning. So again, those are my recommendations. You'll need to introduce power scheduling as you feel appropriate, and I have that outlined in the Metrics That Matter PowerPoint. This is an example of the scheduled hours. It's very wordy here, but just again, this gives you an idea of how we ran our schedule in the clinic. I had 3 interns and 3 residents in the same facility, and so we chose this sort of overlap with our schedule to allow us the amount of traffic jam and the most flexibility around the intern training and resident training days. Tech schedule. Those of you that are in managerial roles in your clinic, or you may communicate to the managers of your clinic, early on in the internship, the interns really function as their own techs. Meaning they're able to wipe their own tables, they're able to help out with refurbishing an exam room. They are side by side, one-on-one throughout the entire episode of care with these patients, which arguably is a good thing. I would say that most of our interns are probably better prepared for functioning as a care extender than most of our techs are, even though many of our techs understand how to set up basic exercise, but monitoring that really falls on the role of the PT in our clinics, and having an intern who can sit side by side throughout that entire process is very helpful. But you don't want to have, in a busy clinic, you don't want to have excessive bodies standing around that. Now that the interns are able to take their patient off the bike and move them to the mat and get their own TheraBand, that you really don't need the extra bodies. That will tend to diminish a little bit and return to somewhat normal once the intern picking up more than about 8 patients a day. But it still stays less because they're able to be with their patients predominantly throughout the whole time. Track the stats. Do this from day one. If your software, scheduling software, doesn't track your lost visit rate or your total visits or total evals, I've attached just a very basic Excel spreadsheet. I would have your interns self-report and monitor that for you, and compare. What you don't want to do is end up with one intern averaging about 8-9 patients a day and the other averaging about 6 or 4, and that'll help you look across the board and also at their lost visit rate. This is a key metric, and we'll talk about this in the Metrics That Matter component. It's a key metric for customer service and patient loyalty. Watch that closely. If you start to see that rise, then my belief is that the clinical faculty member is not doing an adequate job connecting with the patient and making sure that you're elevating that patient's experience. Here are some of the internship checkpoints. This is just simply a way to look at it, sort of a completion of the orientation and basic skills checklist. Then moving into the hypothesis-driven exam, grand rounds format, and then the lower and upper quarter screenings. Something that we've done a couple times in-house just at our locations, and this is certainly not something that is a part of the SIN specifically, was put together a chief intern challenge. In other words, sort of a competition of sorts, where you're able to identify really who the peak performer is in the interns. Just a brief description, what we did was we had a couple of primary care physicians come over and actually had a live patient, and the intern would go through the history and the medical systems review with the physician present. Obviously, these were predetermined cases, and the physician was able to ask questions and query on medical screening, and then the intern would perform the physical exam on the patient, who was often a resident. So who would judge them on their hand skills and their communication skills, and then they would perform one peripheral manipulation, one spinal manipulation, thrust and non-thrust of both of those, and then exercise, would teach an exercise to the patient. And they were just scored on a very simple scale. If any of you are interested in that, I can provide you sort of the rubric for what we used. But it was very helpful for the residents and the interns and the physicians to all sort of see what we're doing. Okay. Those of you that know me know that I like football, and specifically one particular college team. And I want to talk to you for a second on technically how your role as the clinical faculty and football sort of go together. Oh gosh, I forgot that was in there. I'm so sorry for those of you that are non-SEC fans. As the clinical faculty, think of your role like a wide receiver coach. You need to make sure the player has enough of the basics to be able to complete some of the passing routes. Okay, so do they know how to do a silent snap count? Do they know how to do a bump and run? Then you need to be sure that they know the routes that are in the playbook. In other words, every receiver knows how to run a wheel route, but do they know that a blue 52 means that they run the inside wheel route, but they have to stop short because they'll hit the tight end? Once you've established the baseline for both, then go back and spend your time fine-tuning the technical skill to make the routes smoother and better. Okay, so let's put this into PT world. So the physical therapy school has hopefully given your intern basic skills, okay? How to screen for the red flags, how to measure range of motion, how to perform special tests. Your job as the clinical faculty is to show them the playbook. In other words, how to take these basic skills and put them together to get a pattern or get through a clinical exam. The intern may be able to complete a few first downs successfully. In other words, it may be sloppy. If you go back to the football analogy, you may see somebody whose their patterns are sluggish, or they didn't really get off the line at the snap as quickly as they should have. In the physical therapy world, we may see first downs where they do well, but make mistakes like being rough with their hands, or really just too many tests, or they didn't use the test-retest model. So this is when your role as the clinical faculty can fine-tune the techniques and ultimately help them become better. So just to make this a little bit more clear, I've organized some of the following thoughts into a technical skill and then, of course, the playbook. So let's look at the playbook first. So this is the question you're answering here is, how effective is the intern doing the following things? And these are in a logistic order. So I would start with the generate the hypothesis list. Can they effectively do that? Then can they select appropriate tests and measures, ruling in and out pathologies, classifying the patient according to best evidence guidelines, etc. So you can see the pattern here. So this is the playbook. So how effectively can they do this? Then we're going to get into the technical skill. How accurate is the question now that you're asking? How accurate are their communication skills in terms of matching the communication style to that of the patient? How accurate is their objective exam? Are they using the flashcard approach? Are they delivering accurate hand placements in their physical exam maneuvers? Are they responding to new information accurately? In the intervention and follow-up planning, etc., these again, how accurately, from a technical standpoint, is the intern performing these? And here are three more. Again, how accurately is the intern managing their time within the visit with one patient? How accurately are they managing their time across visits, from visit to visit within one patient? Or how accurately are they managing their time across the day with multiple visits? All right. So that's the idea. Through some bumping and pushing and training and stretching from us as coaches, we can develop champions. All right. Thanks for your time. I hope this bit of information has been helpful for you. And again, don't hesitate to shoot me an email or a text if there's any way that I can help you reshape and build tomorrow's physical therapists.